Thank you so much for the invitation and giving me this opportunity to talk about our work. I really appreciate that. These are my disclosures. Instead of talking about anything about the background of ketamine, I know you're much more familiar and knowledgeable about ketamine than me. So I thought maybe I introduce a little bit about MS and MS fatigue instead of talking about ketamine. So multiple sclerosis is, in fact, an inflammatory demyelinating disease of the central nervous system, which is thought to have an autoimmune origin, most likely. It's relatively common. It's the most common cause of disability in young adults after trauma. And the hallmarks of MS are focal neurological deficit that kind of happen subacutely, affecting optic nerve, brainstem, and spinal cord. And usually they have a relapsing and remitting pattern. Those are the hallmarks. Also, there is a phase of gradual progression that can happen either at the beginning of the disease in people who are primary progressive MS or happen after several years of having relapses. That's called secondary progressive MS. Those are the core symptoms of MS. But aside from the core symptoms, patients also have many chronic symptoms that are not necessarily classic neurological symptoms. Symptoms such as fatigue, altered mood, cognitive dysfunction that happen in the background of the disease and add to the burden of disability in this condition. Fatigue, as defined as an overwhelming feeling of tiredness and exhaustion, which is a subjective symptom. That's very important to emphasize. This is a subjective symptom. There is no objective or external manifestation of fatigue. Fatigue, if you define it this way, is actually the most common symptom of MS. Depending on the study, more than 75% of people with MS report that either chronically or at least at some point during their disease, and is a major cause of disability, actually. Has been associated with unemployment, lowered quality of life, and actually hand in hand with walking dysfunction. Walking dysfunction, that is kind of, again, one of the hallmarks of MS. Fatigue has been associated with disability as much as walking dysfunction. So it's a major issue in MS and a major problem in MS. So what is causing fatigue in MS? I would say probably it's kind of a perfect storm that many different factors that each one by themselves can cause fatigue in a condition. MS has many of these different factors present at the same time. So for example, inflammatory diseases generally cause fatigue, and that's present in MS. Hormonal abnormalities can cause fatigue, that's present in MS. Changes in the brain, functional structural changes in the brain can cause fatigue, and that's present in MS. So it's probably a multifactorial condition, many different factors, the most salient being inflammation, either in the brain and the spinal cord or peripherally, and a structural damage in the brain and the spinal cord. These two are thought to be the dominant factors underlying MS fatigue. And again, this cartoon showing the multifactorial nature of MS fatigue with inflammation, both in the periphery and in the central nervous system, as well as the damage in the white matter and gray matter probably being at the root cause. So how do we address fatigue in MS? We said that it's a huge problem. It's a major cause of disability. It's extremely common. How do we address that? So there have been many studies, as you can imagine, looking at different modalities, pharmacological and non-pharmacological treatment for fatigues. In fact, the bulk of evidence supporting any type of treatment mostly support the non-pharmacological interventions, including different forms of exercise and cognitive behavioral therapy. Different forms of cognitive behavioral therapies have been shown to be effective in improving MS fatigue. There is no medication approved by any authority for MS fatigue. And in fact, the evidence supporting the use of medications for MS fatigue is very thin. Despite that, many neurologists, psychiatrists, primary care practitioners, general practitioners still prescribe different medications, including the most common being amantadine, modafinil, and amphetamine-like stimulants for MS fatigue. And in a randomized controlled trial that recently finished and published the results in Lancet Neurology, we compared all these medications with placebo, and we showed that their effect on MS fatigue is as good as placebo. So basically not supporting the use of the medication that we commonly use for fatigue in MS. But is it a lost cause using pharmacotherapy for MS fatigue? I'm hoping that's not the case. So several years ago, when I was a fellow, I became interested in the association of glutamate and MS fatigue. And the interest came from basically my mentor had done a randomized controlled trial of Riluzole, which is a medication that is approved for amyotrophic lateral sclerosis as a neuroprotective agent. She tried that in MS to see if it has any neuroprotective properties in MS, which it didn't have any radiological or clinical neuroprotective properties. But fatigue was also measured as a tertiary outcome. Interestingly, people who received Riluzole as compared to those who received placebo, they showed continuously worsening fatigue during 2 or 3 years of the clinical trial. And the salient mechanism of action of Riluzole is thought to be blocking glutamatergic neurotransmission in the central nervous system. So I thought maybe blocking glutamate chronically might be one of the causes of fatigue, or maybe glutamatergic neurotransmission could be harnessed as a therapeutic modality. I looked at other clinical trials of medication that chronically block glutamatergic transmission. So memantine, that you might be more familiar with, it's a medication that is used for symptomatic treatment of Alzheimer's disease and is known to be an NMDA receptor blocker. There were at least 3 randomized controlled trials of memantine for cognitive dysfunction in MS. None of them showed any positive effect on cognition, but all 3 RCTs reported worsening fatigue as a side effect of memantine. So that was another clue that maybe glutamate and an NMDA receptor had any association with MS fatigue. Interestingly, our psychiatrist colleagues actually reported the effect of ketamine in one of their clinical trials, that they use ketamine for mood disorders in patients with bipolar depression. And fatigue was measured as an exploratory outcome in this clinical trial. So they published the results, and fatigue was, not surprisingly, was measured by a questionnaire. Specifically in this study, it was NIH brief fatigue questionnaire. That's what administered in this study that was done at the National Institutes of Health. This was the baseline characteristics of patients in that clinical trial with average age of 47, 18 years of mood disorder. And this was what they reported. Very interestingly, ketamine very quickly, 40 minutes after the administration, they saw a separation in the self-reported fatigue between placebo and ketamine. That effect lasted until day 14, with all the time points being statistically significant except day 7. But that was quite interesting. However, in a subsequent publication, they reported that the anti-fatigue effect of ketamine disappeared when they controlled for the effect of ketamine on depression. So basically, they thought that the effect of ketamine on improving fatigue in these patients with mood disorder was explained or was mediated by the effect of ketamine on amotivation and depressed mood. So that all these background was a motivation to look at the effect of ketamine in MS fatigue. My colleagues and I performed this small pilot trial of ketamine in a small group of patients with MS fatigue. So it was a randomized double-blind placebo-controlled trial, and as a placebo we used midazolam. Again, you're familiar that it's been used as an active placebo in several ketamine trials for mood disorders. We recruited 18 patients. We randomized them 2-to-1 to either a single infusion of ketamine or a single infusion of midazolam. 2-to-1, so 12 patients receiving ketamine and 6 patients receiving midazolam. Of course, they were all randomly assigned to these interventions. These are the eligibility criteria of our clinical trial. The eligible patients were 18 to 65. They had a known diagnosis of MS. They were not extremely disabled. They were able to at least ambulate 20 feet. They should have self-reported fatigue and their modified fatigue impact scale, which is probably, I should have talked more about this scale. It's one of the most commonly used and one of the most validated scales for MS fatigue. So they should reach a threshold during the screening. And because we were trying to do the study with the lowest burden on patients, so we wanted to do all the questionnaires remotely, so they should be able to operate the computer and have access to internet. We excluded patients with severe depression, with patients who had a BDI score of more than 30. And the other exclusion criteria were mostly related to the safety of ketamine, basically. So the interventions were basically the same ketamine use that's usually used for mood disorders in psychiatry. It was 0.5 milligram per kilogram of ketamine infused over 40 minutes, and midazolam was 0.05 milligram per kilogram infused over 40 minutes. Very similar to probably the most commonly used dosage for depression clinical trials. The infusions were done right after the screening visit, and all the study outcomes, aside from the screening visit, the baseline variables were done through a web interface remotely. So what were the study outcomes? I apologize because I made the slides very in a short notice. Probably I forgot to mention what the primary outcome was. The primary outcome of the study, because we had no idea about how fast the ketamine works for MS fatigue or how long the effect lasts, our primary outcome was a daily fatigue severity scale, basically a Likert scale 0 to 10 scale, asking the participants at the end of the day how they how they rated their fatigue severity during that day. So we asked that question every day for 7 days post-infusion, and that was our primary outcome. For secondary outcome, we actually used more validated questionnaires, including Neurology, fatigue item bank, fatigue severity scale, and again, modified fatigue impact scale, which I mentioned is probably the most validated and commonly used in MS literature. We, of course, looked at measures of depression with the BDI and Epworth sleepiness scale as a measure of sleepiness, as a symptom that goes hand in hand with fatigue. The sample size, we thought 18 patients were enough to see 3-point difference in daily fatigue score, which was our primary outcome, would give us enough power, 80% power, to detect a 3-point difference. So we recruited 18 patients, and for the analysis of primary and secondary outcome, we used a mixed effect model that is commonly used for longitudinal data. So you see, it's a very easy Consort diagram. We assessed 18 patients. They were all eligible and were randomized, 12 of them to ketamine and 6 to midazolam, and we didn't have any dropout for the primary or secondary outcomes. So these are the baseline characteristics of patients. There were some inequality, basically, between the two groups, unfortunately, despite being a randomized control trials. So, for example, patients in the ketamine group, participants in the ketamine groups were younger than the midazolam group, although it was not significant. But maybe more importantly, their depression score was significantly lower than patients in the midazolam group. Also, their sleepiness score was relatively significantly lower than patients in the midazolam group. So when you interpret the results, these discrepancies, I think we have to consider them when we interpret the results. So basically, ketamine group were younger, less depressed, and less sleepy than the midazolam group. Also, probably a little bit less fatigued. If you look at their screening modified fatigue impact scale of 48 against 44 on a scale that is 0 to 84. So a little bit less fatigued as well. So what were the results of the study? So the primary outcome of the study, which was daily fatigue severity for the first 7 days, we did not see any difference between the midazolam and ketamine group. Both on average experienced almost really no difference from baseline. But interestingly, at the end of 28-day study, so the MFIS has a 28-day look-back period, so we administered it only at that point. There was a statistically and clinically significant difference between the ketamine and midazolam group, with midazolam group almost staying flat, but ketamine group experiencing almost 0.5 per day decrease in their fatigue severity. And it actually, despite our very small sample size, reached statistical significance, but definitely it was also clinically significant. It was also true for the subscale of MFIS. It has physical and cognitive and psychosocial subscales, the main subscales being physical and cognitive. And as you can see, they were either statistically significant or at the verge of a statistical significance. The same was also seen for another very commonly used and validated fatigue measure in MS called fatigue severity scale that was administered at the end of 7 days because it has a 7-day look back period, and it was almost statistically significant. So two very well validated scales showed an improvement of fatigue with ketamine at the end of 7 and at the end of 28 days after a single infusion of ketamine. Granted that our primary outcome was completely negative. Very interesting, we didn't see any effect of ketamine on the BDI score and also on the Forte sleepiness score. So this is kind of the, as you can imagine, clinical trialists, they want you to see their most positive result and their most salient result. So this is our most salient result, clinically and significantly important decrease of MFIS score at the end of 28 days after single infusion of ketamine as compared to midazolam. And actually we could see the same with the major subscales of MFIS, including physical and cognitive subscales. So we had this question, basically, whether the effect of ketamine on depression, whether the effect of ketamine on fatigue was mediated by its effect on depression. And we did the same thing that our psychiatrist colleague had done in their reports. We adjusted the models for the baseline or change from the baseline of the BDI score. And those adjustment did not make any difference in our results. So our change in the fatigue by ketamine was not mediated by the change in depression scores. What about the adverse events? So we collected adverse events right after the infusion, during the infusion, right after the infusion, and up to 1 week after the infusion. The adverse events were mild to moderate. There was no serious adverse event. And the most common adverse events, I would say, were the one that you would see in clinical trials or clinical use of ketamine in psychiatric disorders. The only thing that was different and was kind of unique to MS was a big proportion of patients who received ketamine reported numbness or tingling or worsening in numbness and tingling, interestingly. So 10 out of 12 patients reported worsening numbness and tingling right after the infusion, which resolved quickly. And in 1 week after the infusion, there were some reports of adverse events, which we don't think was necessarily related to the study medications. And as you can imagine, midazolam, the only adverse event was sleepiness or drowsiness during the infusion. So the main point, the main results of this study was we did not see an effect of ketamine on the primary outcome, which was a single question about daily fatigue severity up to 7 days. However, using traditional, better validated, more comprehensive fatigue measures, such as fatigue severity score and MFIS, we saw a clinically and for some of the measures a statistically significant improvement in fatigue at 1 week and up to 28 days after a single infusion of ketamine. And ketamine infusions were generally well tolerated, and the adverse events are transient and mild to moderate in severity. And the effect of ketamine on fatigue was not associated or was not mediated by its effect on depression. So of course, this was a very small pilot study. We did our due diligence about trying to reduce the numbers of confounders and try to mask the intervention as much as possible. Again, you may imagine it's probably impossible to mask the effects of ketamine. But we tried our best. But the questions remain, are these effects of ketamine and MS fatigue real, or what we saw were just by chance or false positive, particularly considering that our positive results were actually the secondary outcomes, not the primary outcome of the study. If these effects are real, how long these effects would last? We showed in the study that the effect may last up to 28 days. Can those effects last even longer? That's a possibility. Is repeated infusions of ketamine better than a single infusion? We don't know. And of course, ketamine, as you know better than me, is not the only medication that targets glutamatergic pathway. There are more modern or even more archaic medications that affect the same pathway, and what would be their effects. So I have to thank the National MS Society for funding this pilot study, and thank you for your attention.
Great. Well, that's really interesting. Thank you very much indeed, Bardia. We've got a couple of questions in the Q&A, so we'll go straight on to those, and that might give other people a chance to think about any things that come to them. And the way that we do this, I'll just read out the questions, probably easiest. And we'll, so the first question is from Antonio Metastasio. Do you envisage the use of small dose ketamine in other conditions like chronic fatigue?
That's a great question, and I think until we try, I cannot make a prediction really. There has been some dissociation between MS and chronic fatigue syndrome in terms of interventions that have been shown to be effective. For example, as I mentioned at the beginning, cognitive behavioral therapy has been consistently shown to be effective in improving MS fatigue, but based on my limited data about chronic fatigue syndrome, CBT has not been shown, at least consistently, to be a good therapeutic modality for chronic fatigue syndrome. So because an intervention helps fatigue in one condition, it doesn't necessarily mean it's gonna be a universal treatment of fatigue in other medical conditions. But again, this is hypothesis generating, and I think for recalcitrant conditions such as chronic fatigue syndrome that we don't have many options, it's not a bad idea if someone does a clinical trial of ketamine in that condition. So
yeah, well, okay, we'll come back to that in the discussion, and I think also we'll deal with Ramesh's question about biomarkers then. Let's just try and stick with the MS side of things for the moment. Steve's question is also about chronic fatigue. I have some questions about the study and about MS. Can I just wanted to clarify the thing about the primary outcome. So you basically had a Likert scale over, and did they complete that every day for 7 days, and it was like the mean of that, or
correct
sort of
so
curve,
it was a curve similar to what I showed you for
after 7 days, yeah.
Exactly. So yeah, it was this question was asked from them at around 9 p.m. at the end of the day, because it's known that MS fatigue has a diurnal variation. Usually it's more severe later in the day. So this question was asked around 9 p.m. every day for 7 days.
And so they had to be able to get onto the internet at 9 o'clock and fill their forms in then. Did you, I mean, this is a hypothesis generating study, so, the whole thing's a fishing exercise, so you might as well fish hard. I mean, did you see anything happening at at day 1 and day 2 that waned by
There
day
was a separation early on. Yes, there was, but the separation was small. So there was an improvement, maybe 1 or 2 points in the first few days in the ketamine group. Yes.
Okay. All right. I had a question about the tingling as well. I thought that was a bit, I mean, I've got a patient with MS who came and asked for ketamine, and to be fair, her main symptom wasn't fatigue, but I thought, I looked at the memantine data and thought, well, the fatigue makes fatigue worse. That's memantine makes fatigue worse. That's all I had to go on really. So I didn't give it to her, and obviously she was quite upset. But it made me, your thing about the tingling being worse did just make me wonder, how you would design a study next time round to really max out on the safety.
So it was very transient. It just happened during the infusion.
Oh, I see.
Or right after the infusion. So there was no long-term worsening of their neurological symptom. It was very consistent, and it was something that I didn't expect. And I'm not sure about the mechanism, but 10 out of 12, and without any priming, they reported this worsening of tingling or numbness, again, different areas of the body, several patients on the face, several patients on the extremities. But again, it was very transient, and I would not be concerned about that.
Didn't make you think about trying a glutamate agonist for tingling as a symptom?
Good question. Actually, it didn't occur to me, but that's absolutely a great idea. Yeah.
You might want to give them put them on some Tegretol first. Okay, and on your while we're sort of trying to fish in the data, the items that were in the scales that turned up trumps, that turned up positive between 7 and 14 days, or 7 days and 28 days. What were the things that caught your eye there? I mean, because both the subscales, the physical and cognitive, both came up. But if you look at an item level, what would you be looking to try and pin your hat on a bit next time round in a bigger study?
Great question. So that's actually, I didn't look at single items. I looked just at the aggregate, but I do have available single item responses for all the questionnaires, and definitely.
What sort of questions do they ask? What sort of questions are on those scales?
Do you have time? I can show you in a second. I can show you in a second what type of questions. Again, when you look at the questions, you may think that there is a huge overlap between what these questions measures and things like cognition. So if you give me 1 second, exactly. I'm gonna show you.
The Beck is big on cognitive aspects of depression rather than the physical endogenous aspects. So,
absolutely. So this is the modified fatigue impact scale. That's the one that I told you. It's probably the most commonly used in MS literature. So I've been less alert. I've had difficulty paying attention for a long period of time, and you can imagine these are mostly cognitive. I've been unable to think clearly, clumsy and uncoordinated. That has a huge overlap with the physical manifestation of MS, not necessarily fatigue, being forgetful, again, huge on the cognitive part, able to pace myself, motivation.
I can sort of see why you chose to go for the pure sort of fatigue single item Likert scale, you know, because this has got a lot of overlap with other stuff, hasn't it?
With other stuff, correct? That's true. That's true. This is.
So what was your single item question? Yeah.
Our single item question, again, I can tell you exactly the wording. 1 second. All right. So the single item, the question was how much fatigue or tiredness, weariness, problems thinking clearly. So kind of incorporating both physical and cognitive fatigue. Have you felt today with the response ranging from 0, none at all, to 10, which was extreme fatigue? So this is a question that's not been validated or tried, but it was kind of made in-house for an intervention that we didn't know how long the effects would last.
So if you were doing this study next time, have you decided what, I mean, if you were going to go out for another grant to do a bigger study on the basis?
Actually, I'm going, hopefully, I'm the Department of Defense in the US, they have annual funding for MS-related projects. And this year, they are funding clinical trials for MS symptoms. So I'm proposing a larger trial of ketamine, including also multiple infusions, to see if multiple infusions are more effective, and also following more than 28 days, actually 2 months, to see if the effects last longer as the primary outcome, because the reviewers know and like modified fatigue impact scale. I will be using this as the primary outcome, as my primary outcome, modified fatigue impact scale. And again, a little bit selfish because it was positive in that trial. So it has a higher chance of being positive.
Yeah, it's completely understandable. It's got a lot of overlap with depression as well. But